Welcome all to the ISA online PG classes. Today we have amongst us Dr. Amit Kohli, who is an active member of ISA National Task Force on COVID and an integral component, active member of Yuva ISA also, and was closely associated with Yuva ISOCON. Today he shall be discussing about anesthesia at remote locations. I request Dr. Nishant to please start the proceedings.
Thank you, sir, and welcome all to the ISA Online PG classes. It is my proud privilege to introduce Dr. Amit Kohli. Dr. Amit Kohli, sir, is a faculty associate professor in the Department of Anesthesiology at Maulana Azad Medical College in New Delhi. His area of interest is critical care medicine and difficult airway management. In fact, he is the course director and instructor of Advanced Airway Skills Workshop, which is run by him and his team. He has many publications, more than 60 in more than 42 in PubMed Index journals. He has 5 review articles and 3 chapters in books, and has been invited for guest lectures at various national and state level conferences in anesthesiology. He's also a thesis assessor and MD examiner for various universities. He's the governing council member from ISA Delhi and the Delhi coordinator of ISA National Task Force on COVID management. He recently edited a book, The Essentials for COVID for Anesthesiologists, and has been awarded the President's Appreciation Award and the Proficiency Award in 2021 by the ISA National. So it is a proud privilege to have you, sir. And the plan for the day is we will keep all the participants muted. Dr. Amit Kohli will be presenting his lecture during this course of time, and all questions or queries that the listeners might have, they are encouraged to type in the chat box. Just in case there are any questions by Dr. Amit Kohli, the listeners are encouraged to answer that again in the chat box. And all the questions and queries will be discussed once the lecture and the talk by Dr. Amit Kohli is over. For the duration of the presentation, everyone will be muted, and Dr. Amit Kohli can, sir, you can start your presentation.
Yeah, sure. At the outset, I really want to thank Naveen sir and Dr. Nishant for a very warm welcome. Naveen sir is like a mentor and an elder brother, and giving an opportunity to interact with the young minds today. That is a great privilege, and being introduced by a dear friend of mine, Dr. Nishant, it's again a privilege for the day. Hello friends, today as has been introduced that I'll be speaking on a very important topic, that is anesthesia for remote locations. That is there. I hope, Nishant, the screen is visible.
Yeah, Dr. Amit, screen is visible, and now all the participants will be muted. You please unmute yourself.
Yeah. So when this topic is allotted to me, that this is a postgraduate forum, right? Dear friends, you should be knowing that what topics are important from your theory point of view and what topics are important from practical point of view, right? These two things are very important, right? Because theory, you have to structure your answers. You know, you have to give thoughts to your the words to your thoughts, whereas in practicals, the channels, the aspects which you learn in the operation theaters, these are important for you to know. As far as my talk for today is concerned, yes, it is a topic mostly being asked in your theory examinations, right? Whenever I present myself in any of the postgraduate forums, the first thing that after the topic being allotted to me, I scan I usually scan the question papers of the various universities, including my own university, that is the Delhi University, that on that particular topic, what kind of questions have been asked in your exams, right? That is there. After scanning of the last 10 years question papers, what I could gather is that the questions which have been asked is discuss the anesthetic considerations in an MRI unit or an MRI suite, Another university asked, discuss the anesthetic management of a 3-year-old child posted for contrast enhanced CT abdomen. So CT scan, MRI, these are things have been asked in your, and the anesthetic concerns and the management. Again, the question is same, almost the same asked in a child for contrast enhanced CT scan. They haven't mentioned what is the area. Then the question have been asked on anesthetic concerns during the ECT, that is an electroconvulsive therapy. So these are the important areas, you know, and the questions have been asked in the exams related to the particular topic which is allotted to me. So we'll just be discussing initially what all a postgraduate should know in this particular topic and how to frame the answer when asked in your theory examinations. So any question, if you want to score highest in your examination, right, the layout of your answer is very, very important, right? Whenever you read your question, you should take a while to begin with to formulate the main structure or the layout of your examination, right? So for this particular thing, if you can start discussing it under the few headings, like what is NORA? NORA is non-operating room anesthesia. Then what are the anesthetic concerns? That is, what is the 3-step approach? Then you should be discussing your salient features regarding the pre-anesthetic checkup of a case which has been given to you for anesthetizing in remote locations, say MRI or CT scan. Then what all monitoring standards, and specifically you should be knowing what are the ASA standards you should be mentioning. Then what are the choice of anesthetic techniques you should be using for getting that particular procedure done. In short, you should be mentioning that why have you selected this anesthetic technique, means that what are the pros and the cons, you know, that what are the advantages of selecting, suppose if you're getting it done under general anesthesia. So what are the advantages of getting selected general anesthesia, and why you haven't selected, a brief word about why you haven't selected your, say, sedation, and why you prefer general anesthesia over sedation. So bit of points regarding that. Then what all medications you are selecting, this should be important, and what is the rationale, why you have selected these particular headings, this is important. And then what are the complications and the brief management of the complications, if at all the complications occurs while getting the procedures done. So this is how you have to structure your answer in these particular headings. If you write in these headings, your examiner may easily get an impression that you know your subject, right? There are enough number of copies which the examiner has to evaluate, right? So on one copy, believe me, he or she is spending not more than, say, 10 minutes, and 10 questions are there. So almost 1 minute or maximum 1.5 minutes for each question. So you have to plate your answer like that, that your examiner gets to know that you know maximum about the topic asked. Now, moving from here, the layout of the question, now we'll be moving on to the main topic, that is non-operating room anesthesia, means anesthesia away from the operating room. So how do you define it? My first point was, what is NORA, right? So NORA refers to anesthesia that is provided at any location remote from the away from the traditional operating room, right? Because the surgeries are being done in the operating room, right, where there is a controlled setting. So when you are moving away from your comfort zone, that is your operation theater, that particular place is known as non-operating room anesthesia suite. These locations include radiology departments, there may be endoscopic suites, there may be MRI and CT scanners, or there may be much more. We'll discuss many of these aspects as and when my talk progresses. Now, you must be very, very familiar with this particular picture. It's a very, very fascinating picture, right? That is particularly there, a beautiful, forest where there are plenty of animals, which is there. And among the animals, you can see one tiger also, one deer also, right? And there is a monkey, and even the birds are as well there. What I want to convey from this particular thing is that the particular person who is going to give services in any of the remote surroundings, they may be alien to each other, right? They may not be familiar to each other, right? That is there, and they may not be knowing what danger is coming the next moment, right? That is there. So one don't have to be like these animals. They are predators on each other, right? You should not be like that. You should expose yourself to your predator in an unfamiliar surroundings. So the important message from this is that you should anticipate whenever you are working in an environment which is not familiar to you. You should anticipate what problems I may be facing, what are my rivals there, and how can I overcome those rivals, right? That should be the part of planning. According to Royal College of Anaesthetists, any location at which anesthesiologist is required to provide general or regional anesthesia or sedation away from the main operation theatre. This is the definition of NORA as per RCA, that is Royal College of Anaesthetists. It cannot be guaranteed that the help of another anesthetist will be available or not. This is an important key point, right? That is there. In operation theatres, we have a team. We have a senior anesthesiologist, we have a resident anesthesiologist, we have a technical staff. So it's an entire continuum, right? So you're more relaxed in that scenario, but maybe it may happen that at peripheral settings, you may not even have another trainee with you, right? So what are the aims of NORA? Aims of first and foremost is the safety of your patient is important. Standard of care and patient monitorings are same regardless of location. Right? You should not be feeling like that it is just a 10 minutes procedure, you're getting it done in a peripheral setting, say just a CT scan. So, and if you're getting a surgery of 2 hours done in your operation theaters, so a message clear cut, which I want to give here is that the preparation, the planning, everything should be same for a 2-hour case under anesthesia and a 10 minutes procedure under anesthesia in a peripheral setting. You should not be lax or casual depending on a short procedure, short duration, or minimally invasive procedure, right? Minimize physical discomfort and minimize the pain to the patient. Patients may be very, very anxious, so control the anxiety, minimize the psychological trauma, and maximize the potential for amnesias. Control movement to allow safe completion of procedure. This is very important. At times, most of the times, in specifically radiological suits, your radiologist wants a complete immobilization, nothing else in your patient. So you should be knowing how safely you can immobilize your patients for the scan. Suppose your patient moves in between, the images are distorted. The entire sequence you have to repeat again. So you have to have a very nice planning that in one go only, how can you give a best images to your radiologist? Return the patient to a state in which safe discharge from medical supervision is possible. That is particularly important. So coming to the second part of my layout or structuring of the answer, that is pre-anesthetic checkup for NORA. Similarly, history, general physical examination, and investigations are important. I again re-emphasize, you should not be compromising on getting the investigations done pre-procedural, right? As you are getting it done pre-operatively in your surgeries, the same set of standard pre-procedural investigations are warranted in radiological suits or other cardiac suits as well. Anesthesia specific examination includes airway examination. You should always be locating where you will be putting an IV access because your patients may be extremes of age, having a difficult IV access. So pre-procedural, you should be locating the site for IV access. That is important. Proper drugs. History is important, and any patient is taking any drug for comorbid illness, the patient should be continuing it, or if you have to stop it, you have to stop it like you do in any of the surgical procedures. Proper NPO status or the fasting needs to be followed in most of your patients as per the guidelines being given by reputed societies like ASA and ISA. Right, informed consent has to be taken. If your patient is a child, it should be from the guardian, and you should not be complacent enough for checking the consent. Right, the consent for the procedure should be same as the consent for any other surgery. If you're transporting your patient from one place to another, should be accompanied by an anesthetist who evaluates, monitors, and supports the patient's medical condition. The patients may be on mechanical ventilation. The patients may be on drug infusions, specifically if you're taking your patients for CT scan or MRI from ICU. So you should be knowing how to maintain the ventilation en route. The drug infusions should be full enough so that if at all it takes time in transit, your patient should not hemodynamically collapse. So a proper planning is important, right? You should have a portable ventilator, but having a portable ventilator doesn't mean that you should not keep an ambu bag while transferring a patient for CT scan or an MRI, because any ventilatory failure can occur during the transit. One important point which I always emphasize for my residents, that if you're taking infusion pumps along, if you're taking portable monitors along, you should always check the battery status of those equipments before taking the patient from out of OT or taking the patient out of ICU for say CT scan or an MRI. It should not be a hopeless situation that these things stops working in between because battery goes away. Right? So this is a take-home message from this slide, that mere having an equipment is not important. Right? The functionality of the equipment, and it should remain functional throughout the coming at least 2 hours. That is important. Spare anesthesia and emergency drugs should be made available, and notify the persons in the destination area that the patient is in transit. So appropriate preparations to receive the patient can be made well in advance. This is very important, right? If you're moving from ICU, if you're taking a patient from operation theater, you should inform the radiological or cardiological suites that you're starting, and approximate your transit time will be this much, say 15 minutes, 20 minutes, so that they'll be knowing that they should not be putting any other patient, because your patient needs a priority, because that will be done under anesthesia. So a proper communication with the radiological suite and the radiologist, the technician, is very, very important, right? Send person ahead to secure the elevators to prevent delays in transfer. This is a routine protocol followed by in my institute. If I'm taking the patient for CT scan, MRI from OT or ICU, I tell one of the orderlies that please go, lift open karo, lift open karke rakho, we are coming, right? So that these will decreases the delays, that is there, right? So this is important. Initially, I talked about that there is a three-step approach, right? There is a three-step approach, right? To all my audience who are listening to me, anybody can write in a chat box that what is the three components, what are the three people or the components involved in a three-step paradigm approach, right, for a safe CT scan and an MRI. This is a famous three-point approach. If the people can write in the chat box, right, what are the three, components of the three-step approach or the three-step paradigm, right, for radiological suits? What are the three components? If anybody can write in the chat box, it will be very, very happy, right, to find out. This is there, right? So coming on to what I was saying about that three-step approach, right, that is there. The three important points are: one is the patient himself, most important. Other is the procedure which needs to be done, whether it is in CT scan concerns, MRI hona hai, ya fir cardiac catheterization needs to be done, or what is a remote location procedure related concerns, that is important. And the environment in which the procedure has to be done. Environment related concerns are also there. Of course, the center of the pyramid or the center of a triangle or the three-step paradigm is the anesthesiologist himself. So what anesthesiologist has to take care is that he can take care that what is his patient all about, what are the patient related concerns. Secondly, what procedure he or she is getting done on this particular patient, and what are the procedure related concerns. And thirdly, that what are the environment related concerns, right? Whether it is a MRI suite, they may have their own problems. If it is a cardiac cath labs, it has their own problems, right? So that is there. So if you mention in your answer this three triangle, the three-step approach, your examiner get to know that you are a well-read chap, that it is, you have formulated your answer nicely, right? So that is particularly there. So now coming on to this three-step approach, the first component, that is the patient factors. Patients for which you have been called for are mostly, as I told earlier also, they are extremes of age. They may be children, specifically those who are less than 10 years of age. There may be elderly patients. And in the case of gastroenterological, cardiological, and radiological procedures, your patients may be of higher physical status. Your patient may be compromised patients as far as their physical status is concerned. Right, your patients may be having a history of, right, your patients may be having a history of seizure disorders, movement disorders, or muscular contractures may be there. Your patients may have pain related to the procedures. Your patient may be a case of acute trauma with unstable hemodynamic or maybe compromised respiratory status of your patient. Your patient may be an uncovered CT scan, right? So patient's frailty should be assessed related to the remote locations. There may be limit. You may have a limited access to the patient. There may be electrical interface, use of outdated old even our departments are like in those peripheral setups, we try to give accommodators and all, that if the equipment, your best equipment should be at the remote location, because in your familiar surroundings, operation theaters, you have a workforce. In remote locations, you don't have a workforce, you have your single man army. So best equipment should be there. Less familiar with the management of these patients, you may have a lack of skilled personnel, drugs, and the supplies also. So these all things needs to be checked beforehand. So this is very, very important. Now, we all know what procedures are done in the remote locations. I've been saying since beginning, there may be radiological imaging, which includes CT scan or an MRI. There may be interventional radiological procedures, interventional cardiological procedures, say cardiac catheterization or an implantations. There may be intervention gastroenterology, which includes endoscopies. There may be ECT, electroconvulsive therapies. So these are the various procedures. We'll discuss them one by one, their concerns. So coming on to the same triangle, the three-step approach or a paradigm. So one thing was, we have already discussed patient-related concerns. Now coming on to what are the environment-related concerns. Right? Environment-related concerns includes that there may be ionizing radiations and radiation safety issues you should be knowing. You should be limiting the time for exposure to these radiations, increasing the distance from the source of radiations. You should use protective shieldings. That is very important. You should also use dosimeters. Dosimeters are important if at all it is available in the setups. Allergic reactions should be in your mind. Whenever you are getting a contrast radiological imaging done, radiological agents includes iodinated and gastrographin contrast, specifically in the CT scan, whereas in MRI agents, mostly it is the gadolinium which is being used these days. So you should be well versed with what are the allergic reactions which may happen. You should be well versed with what adverse effects these agents have on renal system or the hypersensitivity. Most of the institutes, if you're using dyes or the contrast mediums, you should always be getting a renal function tests beforehand. So you should not forget mentioning in a PAC investigations that if I'm getting a contrast scans done, so I should have a renal function tests, which include blood urea nitrogen and serum creatinine for all my patients beforehand, right? If it's normal, then only you should allow your radiologist to give the dyes or something like that. That is there. So what are the incidents of contrast related adverse reactions? Mostly these days, we are going for low osmolarity contrast mediums, which have lesser reactions as compared to the earlier used ones. Those were high osmolarity contrast mediums. As I already told you, that mostly it is gadolinium which is being used. So you should be knowing what is the incidence of gadolinium chelates, right? That may be very less. If it's a severe reactions, the incidence is almost 0.01%. But 2% is the incidence of almost mild reactions. So mostly the mild reactions are there. With the gadolinium, the reactions are pretty less. But yes, you should be knowing how to manage these contrast reactions. You may have a question in your exams on the management of allergic reactions due to the contrasts. So you should be mentioning that what prophylaxis you can be using or what treatment you can be having in two headaches. Right? So you should be doing pre-treatment with oral methylprednisolone prior to intravenous administrations. Discontinue the causative agents as if you're suspecting, yes, it is the contrast which is causing problem, immediately discontinue the infusion, right? Source of oxygen should be there and start with the oxygen. Epinephrine is the drug of choice. We all know that. Right, that is there. You can also use H2 blockers like samethidine or ranitidine. That should be there. If your patient is going into bronchospasms, you should have an availability of inhaled beta agonist. Right, that is particularly there. So it's an emergency management of an allergic contrast reaction. That is there. Now coming on to the another part of your structured answer, that what are the standards for NORA? That is the ASA standards needs to be followed. You should always, whenever you're going to get this procedure done in your patients, you should have a reliable oxygen source. Not only one source is important, you should be knowing that immediately outside the MRI room or a CT scan room, what is the backup oxygen source, right? Oxygen is the gas of life. We all know that. So we should be depending not only the single source of oxygen in the suite, but just immediately outside the suite, there should be a backup oxygen source readily available. Suction should be there, which should be adequate and reliable. Adequate monitors, sufficient safe electrical outlets that are important. Sufficient space should be there, and you should be checking the anesthesia equipments. That is important as per the ASA standards. Other than routine anesthesia equipments, you should be having an availability of resuscitation equipments, which includes defibrillator, emergency drugs and equipments. Adequate illumination should be there, right? There should be adequate battery backup of all the equipments, whichever you are using. I told earlier also, right? There should be a trained staff for a reliable communication. Most of the time, what happens is that specifically in the radiological suits, the signals, the mobile signals are very, very poor. They are dead zones for mobile signals. You should be knowing how to communicate to your senior colleagues, which may be sitting farther away from the radiological suite. So every hospital or every department should have some kind of a system available that if the mobile signals goes away in that particular settings, that how to communicate to your seniors if you need help. So this should be in place beforehand. Post anesthesia care facilities should be there. There should be adequate staff, and there should be an adjacent PACU if possible. There should be a scavenging system. So for all my postgraduates, equipment checklist for anesthesia or sedation in a remote location, which is away from operation theater, always remember the mnemonic, SOAP ME. SOAP ME is the mnemonic. With this way, you'll never forget that what all is you have to check before taking your patient for procedures. Right? SOAP ME includes S stands for suction, O is oxygen, A is airway related equipments, which would include entire battery ranging from your face masks to your laryngoscopes, endotracheal tubes. Right? That is there. Then coming again to SOAP ME, and SOAP ME, P is the pharmacy, means the drugs, the emergency drugs and the resuscitation and the anesthesia drugs. That is there. M stands for your monitoring. Monitoring includes the again the ASA standards, which includes a pulse oximeter, NIBP, temperature, ECG, continuous ECG, very, very important. And if you are doing it under general anesthesia, a facility for end-tidal carbon dioxide should be there, right? And other equipments include defibrillator, gas scavenging. This we have already discussed. So SOAP ME is the mnemonic for all my postgraduates. Right? Now coming on to the monitoring standards, as we all know, there is a standard 1 monitoring and standard 2 monitoring. Standard 1 monitoring is a trained anesthesiologist, right? We should always be sending our trained anesthesiologists to the remote locations. The trainees can accompany them and learn how the safe and the trained anesthesiologist manages those cases in the beginning years, but the trainees should not be left, right? That is particularly there. Now, what is your standard 2 monitoring? Standard 2 monitoring is a continuous display of ECG, NIPP, pulse oximetry, continuous end-tidal carbon dioxide monitoring. So these are all. This we have already discussed. I am not going into the details that what all equipments are required. I've been emphasizing operation theater. You should be having it in remote location. Simple as that. No compromises, right? Anesthesia techniques used in NORA locations. At times, you may not need any anesthesia. You may just be doing monitoring of that particular patient for doing a short procedure. But yes, again, you should be ready with the backup anesthesia techniques like sedation or even the general anesthesia. So the continuum of anesthesia techniques ranges from no anesthesia to minimal, moderate or deep sedation up till general anesthesia. The anesthesia care depends upon desired level of anesthesia, underlying medical condition of the patient, and the procedures to be performed. So all three. Again, it is almost similar to your triad or the continuum. Now you should be knowing, what are the drug dosages of the opioids or the anesthetic agents which you are using for providing sedation, or the general anesthesia for procedures in remote locations. One important thing which have been used since ages is chloral hydrate. That is a syrup used in children. Some of the procedures can be done even without using anesthetic agents. So if your child is up till 4 months of age, the dose is 25 to 50 milligrams per kg. If your child is more than 4 months of age, you can go up till 75 milligrams per kg of chloral hydrate, right? That is there. Some of the procedures can be done under this solution. Now, again, reminding of, that triangle or the triad, right? So earlier we did your environmental related concerns. We have also done, some patient related concerns, or then procedure related concerns, right? So what are the problems for the patient? Specifically, if you're going for a CT scan or an MRI to be precise, that surrounding is very, very cold. So there are chances your patient can go into hypothermia. So proper covering of the patient is very important. You may use blankets, which are MRI compatible, right? That is there. I re-emphasize, immobility of the patient is very important, right? So you should keep the patient immobile. There may be noisy surroundings, specifically for MRI. So you should be knowing how to, if there is an availability of noise cancellation devices, you should not hesitate using it, or simple ear plugs. The cotton plugs can be given so that there may be, the patient may be even more comfortable. Your patient may be having anxiety or claustrophobic. So you should be, what you do is, at our centers, what we do is, we counsel the patient beforehand. Yes, this may happen. The radiological room or MRI room is like that, right? That is there. But we are available throughout the procedure for your safety, so you don't have to be anxious, right? At times we give handheld bell or a bulb to the patient, that if when between the procedure you become anxious, right, just press that bell or bulb, that we'll immediately respond to your queries. So half of our patients, if you do the psychotherapy before the procedures, their anxiety levels, their and these things, phobias, goes down. So proper counseling of your patient and exposing your patient to the surroundings before the actual procedure starts is important. Now, what are the problems being an anesthetist in that particular suit? As I already told you, that those surroundings may be unfamiliar to you. So it's better you yourself familiarize to the surroundings before you take the patient inside the suit. Specifically, if you're a small child, virtually it happens, you might see that in a CT machine or MRI machine, if you put a small child and when the machine rolls in, your baby disappears. You have no access to your kiddo, right? You should be devising the methodologies or the methods, right? How to, catch hold of your baby's respiration, your baby's circulation, if anything, this happens. This is individualistic approaches, right? That is there. Support services should be there. There should be, problem for anesthetists. Again, there is no piped gases there. The gases may be coming through the cylinders or something like that. There may be not wall-mounted suctions available, right? That is there. It is difficult to resuscitate. If resuscitation is required on the MRI machine or CT machine, it's very difficult to resuscitate. So you should be knowing how to do that also, right? Radiation hazards and reaction to the contrast, you should be knowing beforehand. So this is a part of proper planning. If you know your enemy, if you know what is going to happen, and if you plan accordingly preoperatively, you will never fail. The issues related to CT scan are much lesser, as compared to MRI. That is there. Again, inaccessibility to patient is there. There may be monitor disconnections. There may be kinking of the tubes. Contrast related problems can be there. Allergic reactions, which we have already discussed. Or there may be, if oral contrasts are used, there may be risk of aspiration. That is particularly there. So these are the related issues to CT scan, right? We have already discussed about pre-medication with chloral hydrate. Another thing is that you can also use oral midazolam. For short procedures, CT scan usually lasts for, say, less than 10 minutes most of the time, right? That is there. Sometimes even 2 to 5 minutes only, right? So that is there. So most of our CT scans can be done in sedation. You don't need general anesthesia even for smaller children, right? So you should be knowing your drugs properly. My favorite is oral midazolam, right? The oral drug specifically. Midazolam is there. Oral midazolam, if available at your institute, you should not be hesitate using it, but you should know the proper dose. But we generally use is 0.5 milligrams per kg body weight, at least 30 minutes prior to the procedure. Timing is very important. If you don't have a preparation of oral midazolam available to you, you can also use intravenous midazolam, which is there in your theaters, but that is little, that is the taste is not very good. So what we usually do is that we mix it with the, kind of either the 10% dextrose or an apple juice, right? Take it in a syringe and drop by drop, we can tell the child almost 40, 45, 1 hour before, right? That is there. Child consumes, right? That is there. And Beautifully child gets sedated, with this kind of an oral midazolam preparations. Intravenous sedations can also be used. The drugs we'll discuss later on. Another important technique for neonates specifically. If you're getting done a CT scan in a neonate, which is a very, very small child, the technique is wrap and scan. Wrap and scan means that you don't have to give any anesthetic agent to the kiddo. Most of the kiddos, if they're at your home also, you see, most of the time they just sleep. Whatever loud noises you make in houses also, if child has to sleep, the child has to sleep, right? That is there. The similar thing, but the only thing is the child should be very cozy, in the sense the child should not go into hypothermia. If child is comfortable as the temperature is concerned, child will not move, believe me, whatever MRI sounds are there. So in small children, like neonates specifically, wrap and scan technique is being used very, very rampantly. In addition to that, I must say one more thing, that at times, again, if it's not wrap and scan, right, if a little bigger child, say infants, right, that is it. Again, at times you don't need any sedation for them, right? What is being done is that for CT scan, I'm telling, short procedures, right? What has to be done is feed a child, right? That is there. If child is well breastfed, right, full stomach, child again goes into sleep, and your entire 5 minute CT scan is easily done. That is particularly the very interesting case we have done, 15 days back, conjoined twins, and we have to get CT scan done on conjoined twins. So what we did is, one kiddo, we use this technique, full stomach. The other kiddo, we give drugs. That is there. They were all, conjoined together, right? And easily can be done, because we were a little concerned about that if we give drugs to both the kiddos, there may be an overdosing. If we give less drugs to both the kiddos, they both might not be sedated, right? So this kind of concerns are coming to our mind. So what happens is, if a very small child, say infant, less than 1 year of age, you can even feed a child. If child is comfortable, you can get the procedure done, specifically if you're not using any oral agents or oral contrasts. That is important. Moving from CT scan, now we move on to MRI, that is magnetic resonance imaging. Again, it's a non-invasive technique. So what are the hiccups of MRI? The main difference between CT scan and an MRI is that MRI is time consuming. If you are anesthetizing your patient for MRI, you should be prepared that your anesthesia should last for 30 to 40 to 45 minutes, right? That is there. So it needs a proper planning, right? That is there. Vis-a-vis CT scan, maybe 2 minutes, 5 minutes procedure. Motion artifacts can be there on image. So your patient needs a complete immobilization. As I told you, it's much noisy. There may be a risk of thermal injuries, or maybe effect of magnet is there on ferrous objects. So that is again, and this important, and this thing is there. Now coming on to the next thing, these hiccups in the MRI. So hence, these MRI patients needs anesthesia. It's very clear that your services are required in 100% of these patients. You should also be knowing what are the safe zones of MRI suite. I'm not going into the details of that. That safety is important, that every MRI suite is divided into 4 zones, zone 1, 2, 3, and 4, So that is there. Not anesthesia per se, but it's an additional knowledge you should be having, right? Now, what are the indications for anesthesia in MRI? Again, mnemonic, SLCCC. SLCCC includes, right? That is, if your patient is having infants and children, that is there. Your patients with learning difficulties, your patients with seizure disorders, that also needs an MRI, right? Your patients with claustrophobia, or your patients who are critically ill, So these all patients needs your anesthesia services. That is important, right? I'll be taking the question which is there in the end, right? That is, somebody has asked about seizure disorders. We'll just be discussing that what is the indications of giving anesthesia is the patients with seizure disorders. Now, what are the strong magnetic field hazards in MRI? So this is important. Objects to the magnetic field, right? To the mechanical hat valves, the implantable infusion pumps, right? Regarding those ICDs, right? There may be ICDs also there. So there is one question from my side to, that is there to our residents who are specifically there, that do you know those ICDs specifically, what material they are made up of these days? These are very MRI compatible ICDs. right, who are safe in MRI. So what material those MRI compatible ICDs are made up of? This is my question to all my residents who are listening to my talk today, right? I encourage if they can be answering in the chat box, right? That is there, that what is that material, right, out of which these ICDs are mostly made up of, right? And that is there. There may be orthodontic braces and dentures, and tattoos can degrade the image quality significantly. Injury to patients' personal and equipments can be there. There may be malfunctioning of electronic equipments, monitors, and the infusion pumps. So we should be very, very well versed. This chart we are very familiar with. This I've taken from my own MRI room, that what all you should not be taking inside the MRI. It's a conjoint responsibility of anesthesiologist and a radiologist if an MRI is being done under anesthesia services, right? So you should be knowing that what all not to be taken. You're very, very familiar with this kind of an incident which has happened this was a ward boy, and very tragic incident. He got stuck in the MRI machine, right, and somehow we lost him also. This is an incident from Maharashtra almost 3 to 4 years back, before the start of COVID, right? So we should be knowing that how to prevent this kind of incidences happening from future. So it's a grave something, so that is important. So MRI compatible pulse oximeters, mandatory. Special ECG electrodes and cables are required. So you should be having availability of those things, right? This is their need for acoustic protection during MRI imaging will necessitate use of earplugs. I already told you, if you have earplugs, don't hesitate using it on your patients. If you don't have, cotton can be used for that particular thing, right? So that is it. This is ECG and multi-para machine monitor, which we are having in our MRI suite at Maulana Azad Medical College, right? That is there, which has a special ECG, continuous ECG facility. And that is there. These are the electrodes, that is there. This works on Bluetooth technology, right? Don't have wire connections to this particular thing. Bluetooth functions very nicely. That is particularly there, right? So that is there. In a kiddo, we are using these kind of earplugs, that is there if you want to keep the child calm. So this is our workstation, which we're using, Fabius MRI from Bragger, MRI compatible ones. Yeah, and if you don't have, at least you should be knowing the different components. I'll be discussing that also, that on the anesthesia workstation, MRI compatible components must be used, right? That is particularly there. So this is what I was talking about, right? The cylinders, we all know it should be made up of aluminium, right? That is there. It should not be molybdenum steel, right? That is there. And vaporizers, bimetallic strip temperature compensated vaporizers are not compatible. So you should be knowing what all vaporizers should be used. It should not have bimetallic strip temperature compensation. Preferably a plastic laryngoscope should be used with covered lithium batteries. This is an important point. Endotracheal tube, avoid reinforced tubes. Those flexometallic ones needs to be avoided. PVC ones can be used, right? So that is there. The defibrillators, cathode ray tubes and batteries malfunction in 20 gauge line resuscitation carried outside magnetic fluids, right? There may be malfunctioning. So if you're using suction infusion pumps or a syringe pumps, a good extension line should be made available, and this should be at the foot of the MRI table, far away from the MRI machine. So that is important. So this is our machine, Fabius MRI, which I was talking about, and that is there. This notion we have to, take it out from our minds, that MRI room is for radiologists and not for anesthesiologist. It is for both. If you're getting it done under anesthesia services, it is for both. MRI suites have been designed without the considerations for anesthetic needs, right? So whenever any planning of the hospitals, those administrators who are listening to my talk today, head of the departments or something, that while you're planning your MRI suite, there should be a frequent involvement of anesthesiologist, that specifically for the gas pipeline system or the suction system, central suctioning, right? That should be discussed with the anesthesiologist. That is there. Access to the airway is limited. Intravenous line anesthesia circuit must be sufficient length to reach the patient deep into the scanners. So these all preparations should be there, right? This is again one of my favorite slides, that don't expect a Volkswagen, and ensure that your ambassador is not leaking petrol. What I mean is that you should not always be saying, I don't have this, I don't have this, I don't have that, right? That is particularly there. But what all equipment you are having already, at least have a full knowledge of that, right? Many of the places I've seen that the people even don't know that this is available in that particular surrounding, right? That is there. They're unaware about it, that this gadget is there, right? They just scrib about that my department has not provided me with this kind of thing. Yeah, you should be knowing what all your department has provided. Check that thing provided pre-operatively. Most of the time, either you don't know the gadget is there, or if you know the gadget is there, you don't have available resources you have. Do a routine checkups, such as ensuring that the oxygen failure alarms are working. Such a small thing, oxygen failure alarms, they should be working, right? It should not be just done, and there should be regular maintenance of these things, and you should be regularly updated whatever you are having. Even a full tank full of ambassador can save life. You should not only, look for a box spigot. Pre-procedural preparation for MRI, as I told earlier, I repeatedly emphasize there should be a complete history taking, examination, investigations, as you do it routinely in any of the case under anesthesia, right? Patient should be admitted in hospital. This is again very, very important, right? At times we are in a habit that for MRI, CT scan, your pediatric department or your other department of the hospital, neurology or so, directly sending you the patient, right? They are not admitting the patient, and they just be saying, hey, today the patient has just come for an MRI. So a day before or a previous visit in the OPD, they say, just go to this particular area where you will find an anesthetist. He or she will take you for an MRI and your procedure is done. But you should never forget checking that even for a short procedure like CT scan for 5 minutes, your patient should be enrolled in the hospital for that very day. Because if at all some catastrophe happens, and if your patient is not the part of the hospital, you can be sued. So that is there. So checking a consent, checking hospital admission for the procedure is equally important. This is my message to all my youngsters. You should always check. There should be no history of recent URI. The recent URI is not only for surgeries. The history of recent URI is also for giving procedural sedation. Adequate NPO as per the fasting guidelines should be there. The consent should be there, and a functional IV cannula. You should not say, okay, my procedure I'm getting done simple and under oral midazolam or a rectal thiopentone, as somebody was asking. Right? But whatever drug you are giving to your patient, right, by any mean, any route, but an IV cannula should be must, right? That is there. Should not compromise the standards. Limited patient access and visibility, as I have already been saying since beginning, are there. There may be intra-procedural malfunctioning of the equipment, so you should be having a backup supplies. That is important. So the necessity to not move the anesthetic and monitoring equipment when the examination has started to prevent degradation of the magnetic field homogeneity, that is equally important. Now coming on to the anesthetic techniques, as I told you, your child may need just sedation. Oral midazolam is being given, oral chloral hydrate, both the doses we have already discussed, right? The children with disability do not need higher dosages of sedatives, but are more prone to risk of hypoxia during sedation. This is very important. Right, you should not be over enthusiastic in adding on to your sedative dose of your sedatives. Right, time is the key. Give a proper time, not in a haste. Your people may be having a constant pressure from radiologist that you're taking a lot of time. You're taking a lot of time sedating a child. Don't succumb to these pressures. Right, take your good time. By succumbing to pressure, what I mean is don't add on additional dose of sedatives. Right, give time, have patience. It's something like that. That if you're in traffic and a car behind you is honking repeatedly, you should not succumb and give accelerator to your car. It's something like that. A very safe and simple anesthetic technique for newborn and neonate, which I already told, is the feed and scan technique. I add one more word to it, wrap. Feed, wrap, and scan. Right, that is there. Most of the time, neonates, right, get the procedures done in this particular technique. Other sedatives which can be used are thiopentone, which can be done, which can be used with both oral as well as rectal routes. Right, earlier we used to use rectal routes often, specifically for those radiotherapy procedures done in the peripheries. Right, rectal thiopentones we have been using in our training days also, and of late many times also in a dose of 5 to 6 mg per kg. We just put an infant feeding tube through the rectum, and we used to give these techniques. It worked really well, but the problem which we used to face in this, that was a time consuming thing. it was a filthy thing, that is there. With the advent of newer agents, say dexmedetomidine or another safer agents or the cocktail of agents, you can use cocktail of agents, right? That is there. A bit of dexmedetomidine, a bit of oral midazolam, and a ketamine, which I am coming on to that. It's a wonder drug for procedural sedation. So with the advent of all these safer cocktails, since years, many people have stopped using this rectal thiopentone thing, that is particularly there. So now dosing is there. So what are the other sedative techniques which we are discussing? That is particularly there, that is ketamine. Again, those postgraduates who are listening to me today, a question for you, if you can answer in a chat box, that what is the dose of an oral ketamine being used for procedural sedation? The dose of oral ketamine, I repeat, for procedural sedation, say CT scan or an MRI. Ketamine is a wonder drug, can be used intramuscularly, can be used intravenously, as well as the oral route. Oral route is pretty safer, right? And gives a very good sense of, detachment of a kiddo, right? So if anybody can answer that, so I will be more than happy. That what is the dose of oral ketamine? Yeah, I must appreciate Dr. Syed Nazima. Dr. Syed Nazima, a lot of congratulations and claps for you. Yes, the dose is what you have mentioned in the chat box, around 5 to 6 milligrams per kg. And the same dose is for intranasal ketamine also. There are preparations of intranasal ketamine available, right? We have been using intranasal ketamine at our institute also with a very welcoming results. That is there, not only for CT scan MRI, we have been using same dose. It's the same dose oral ketamine, the intranasal also same dose that we have been using it, right? That is there. The only thing which you have to know is that you should be using it almost a good 20 minutes before the procedure, right? So we are also using intranasal ketamine for inhibiting the separation anxiety in kiddos before elective surgeries also. So that is one wonderful thing which is being used. It's my favorite drug, ketamine, a wonder drug. Various routes, pretty safe to use, by various routes. If you're planning for general anesthesia, if the procedure has to be done, yes, you can be using propofol. But just remember, if you're using propofol in a peripheral suite, you should be ready for ventilating your child for a long period of time. You should be having a facility of an operation theater or a well-equipped PACU just next to your procedural suite, right? That is very important, because every patient responds differently to propofol. And my sincere advice is that don't use only propofol as an induction agent for general anesthesia and procedural sedation. Again, use a cocktail of propofol and ketamine that decreases the dose, of both the drugs, propofol as well as the ketamine, right? That is particularly there. Then I'll be moving from propofol to other sedatives. Again, one of my favorites, dexmedetomidine, though it is not, FDA approved for any other purposes other than ICU sedation. But yes, most of us are using for various purposes. And that is particularly there. You should be knowing the loading dose of around 0.7 to 1 mics per kg for 10 minutes, followed by maintenance dose. What we generally use is 0.3 to 0.5 micrograms per kg per hour for maintenance dose of dexmedetomidine. So the favorite cocktail and the safer cocktail for MRI includes oral midazolam, ketamine in any of the forms. Addition to that, if you need more, add on dexmedetomidine. This is one of the favorite cocktails for MRI sedation, which is being used very frequently in safer dosages in most of the patients. But you should be knowing when you have to give sedation, when you have to give GA to your patients. There is a thin line of margin, in that. So a general dictum which I want to give to all my postgraduates: if your child is more than 3 years, more than 10 kgs, has no comorbidities, consider sedation for the procedure first. Don't directly jump onto giving general anesthesia. But if your child is less than 3 years, less than 10 kg body weight, or there may be a lot of comorbidities or co-illnesses, it's always safe to give general anesthesia at first place, because otherwise you tend to mess up giving more sedatives, and then you have an unplanned general anesthesia, which is more catastrophic. So this is general dictum, the age and the weight criteria. Some may sleep without drugs. I'm totally emphasizing in that. Maybe many students listening to my talk They may be sleeping without drugs, right? So it's something like that, that some may don't need any drugs, and a boring teacher or a boring environment can lead to sedation. So which sedation is better? This is a question. There is a substantial variability in the response to each agent between individuals. That is their chain opponent. What do I mean by this is that every patient is a different patient, even for the same procedure. I will not say that this sedative agent is better, this sedative agent is problematic. Whatever you are comfortable with, whatever dosages right, you should be knowing that. It may be individualistic, doses may be individualistic depending on one patient to another, right, or depending on their comorbidities. You should be well versed whatever you are dealing with. That is important. What are the contraindications for sedation? Means you can give sedations, but you don't have to give sedation. If your patient is a difficult airway, there is chances of potential obstruction. It's always better to secure the airway first before taking the patient to the MRI suite. If there is a history of apneic spells, if there is patient is having a respiratory distress, any raised ICT, or patient is a known case of seizure disorders, right? Again, coming on to seizure thing, patient is a seizure disorder, go for general anesthesia, right? Full-fledged securing of the airway before subjecting your patient to MRI suite. If a patient is full stomach or patient have severe metabolic diseases, these are the contraindications of sedations where you have to give for general anesthesia. Now, how the general anesthesia is different in these patients? It's a dual staged procedure. What do I mean by this is, stage one, you have to induce your patient or secure the airway outside the shielded MRI room. It may be your operation theater. If it is much away from your MRI suite, there may be some controlled area outside the MRI suite where you can do induction and secure the airway. And then you have to shift the patient. That is the second stage. So it's a dual staged general anesthesia. It is recommended that anticipated difficult trained anesthesiologist, more equipment. So if you're anticipating a difficult intubation, always do it in your OT and then shift your patient to the MRI suite. As soon as the airway is controlled, patient can be transported by well informing the radiology people. Induction, intubation is all individualistic. Use of the agents are all individualistic. As I already told you, after the recovery patient procedure, the patient should always be shifted to the recovery room. Children should stay at least 2 hours after the scanning in the recovery area. This is very, very important. Don't in a haste to send child back to the department, or you don't know, even your child will go back to the department or directly to the home. So 2 hours is the period when you have to, you have to monitor your child once you have given general anesthesia or any kind of sedation. So this is about how to make an extra long circuits, if the circuits and the cylinder supplies outside. Multi connections has to be, and there. Then coming on to the recovery, once the procedure has complete, now word of drug infusions. Extension of adequate length of ventilating circuits are required. So MRI compatible monitors are must. Many ET tubes are not.
Amit, just go slow. Your audio is breaking.
You have to change them before you take your patient to the MRIs and monitors.
Dr. Amit, just go slow.
Yeah, Dr. Nishant, am I audible?
Dr. Amit, your audio
am I audible?
Is breaking. Just go slow.
Sir, your voice is breaking, sir.
Just go slow. Amit?
I think we lost him, sir.
No, he's there. He's there. He's muted. He's muted.
Okay.
Dr. Amit, unmute yourself.
Dr. Amit, kindly unmute yourself. You're muted.
Am I audible now?
Yeah, you are audible now, Amit. You start with the slide of the long circuits, which the picture you were showing.
Okay, sir. I'll do that, sir.
And your voice is slightly breaking, so go slow. Speak slowly. It is breaking in between, so please go ahead now.
Is it okay, sir?
Your slides, project the slides.
Okay, sir. Right, little unstable in between, sir. Are you able to see the slides, sir, now?
Not yet.
The slides are there on my screen, sir.
No.
They're not visible?
No.
Let me check. What is the problem? Are they visible, sir?
Yeah, you go back to the previous slide, 50th slide.
This one from now?
Yeah, please start.
So, am I audible now?
Audio and video now good.
Okay, thank you, sir. Thank you. I think it was the internet connection went unstable in between. Right. So, friends, sorry for the inconvenience. Right, I'll go from this particular slide which I was mentioning that you should be keeping your child for almost 2 hours after the scanning in the recovery area, because you never know, your admitting physicians may be directly sending the kiddo home. So a 2-hour protocol needs to be followed. In the recovery, we all follow that modified Eldred scoring system, which is a universal scoring system for discharging your patients after the procedure from PACU, right? That is there. Now coming on to a special subset of patients, your IC patients admitted in ICU, they may also require an MRI. Right, they may be on multiple drug infusions, so you should be checking the battery of your infusion pumps. I again re-emphasize that they may be needing higher standards of monitoring because they may be hemodynamically unstable. Yeah, many patients, if they are on having a flexometallic endotracheal tube, you should be changing the endotracheal tube before you shift your patient for an MRI. During shifting, very vigilant about cylinders and monitors and other ferromagnetic objects. Now, what happens if any ferromagnetic object gets inside the field? They can act as a projectile and they can injure, so that is there. For example, the oxygen cylinders, the stretcher, only you can be, managing that. So you should be knowing what may occur. That is important. Right, so these things are there nowadays. This question I asked, my audience today, that what are the MRI compatible ICDs made up of? Here is an answer for you. They're made up of titanium. Titanium ICDs are there most of the time these days, and they're pretty safe, MRI compatible ones. Right, this is important. A short note can come in your exam on this particular thing. What happens? How will you manage if your patient suddenly collapses during the procedure? Right, so first step, foremost step, stop the procedure and MRI machine immediately. Inform a technician and immediately stop the MRI machine. Any personnel who goes inside the area to revive the patient should not have any ferromagnetic material on them. This is important. It is not like that you have raised an alarm and you are asking for a help from outside and help immediately, take materials loaded on them. Only BLS in the gantry. This is important, right? That is there. Attempt to bring the patient out and provide ACLS outside the MRI suite, right? That is important. Requirement to quench the magnet. Uses cryogenic gases to dissipate the magnetic field if the facilities are there. This can create a hypoxic environment if the patient is retrieved from the room in a timely manner, right? That is there. So important point which I want to emphasize here is don't panic. If your patient collapses, inform radiological people, stop MRI, ask for help from outside, start giving chest compressions. Meanwhile, only chest compressions, that is the BLS in the suite. Make arrangements for moving the patient outside the MRI suite in a side area, ACLS there and then. So So you have to keep your thought process intact. Then you can save your patient. So this is all about CT and MRI for today. Right, that is there. I tried to cover all aspects as far as possible. Now, in the last few minutes, touching upon the various other remote location procedures, I'll just be going into touching upon that. Right, that is there. The firstly, electroconvulsive therapy. So, what are the management goals, anesthetic goals in ECT? Right, if you can write your answer accordingly, anesthetic goals are to provide amnesia, proper airway management, prevention of seizure-related injuries, control of hemodynamic responses, and smooth and rapid emergence. If you structure your answer in these headings, you're likely to score highest. So a proper preoperative evaluations, which include a proper history taking of the patient, which may include the patient's current medications. The patient may be on antidepressant medications, which may have interactions with the anesthetic agents. At times, you have to change antidepressant or stop antidepressant before the procedure. So you should be knowing what all antidepressants your patient are on in a PAC clinic. Now, while selecting the anesthesia technique, the proper standards of monitoring needs to be followed. Most of these, or I must say all these patients needs to be pre-oxygenated. General anesthesia is the answer. Induction can be done either with propofol or etomidate. The muscle relaxations can be achieved with succinylcholine, and a supplemental oxygen and a facility or the availability of a bite block is must. That is important from this particular point of view as far as your ECTs are concerned. Post ECT, there should be a facility for oxygenation. You should know what is recovery position and preferably keep your patient for some time in recovery position. Monitor your patient till the discharge criteria are met, and discharge criteria are again mostly those Eldred scoring systems. You should always record the patient conditions, the responses, the extra precautions can be taken during subsequent treatments. The documentation is very important because there may be multiple sittings required on the same patient for ECT. So a proper documentation of how you got the case done, how your patient behaved, and what all post-operative, post-ECT monitoring and oxygenation you have done, how much time your patient took for recovery, all should be well documented so that in the next setting, whosoever anesthesiologist will give anesthesia for ECT, know it beforehand. It will help them out. Now, a word about intervention cardiology. Anesthesia for coronary angiography. PCI may be performed as a part of the same procedure. The usual approach is giving sedation and a bit of analgesia, commonly a combination of a benzodiazepine and fentanyl. Your patient should be given a supplemental oxygen. If you're planning for GA, only and only if your sedation fails. Most of the time, coronary angiographies, if you have been called for in the patients, right, in which the sedation has been failed, or your patient was uncooperative, your cardiologist was not able to do on his or her own airway control in cases of respiratory failure. So these are the main indications why general anesthesia is warranted. Otherwise, most of the time, you may be required for either monitoring or supplemental sedation. Placement of catheters in the heart to allow determination of cardiac anatomy. These are general cardiac catheterization indications. I'm not going into the details of that, but you should be knowing for what you have been called for. Your patient may be hemodynamically unstable, so you should be having availability of resuscitation drugs, availability of inotropes and vasopressors in hands. Most of the time, anesthesia for cardiac catheterization needs mild to moderate sedation. This is the usual approach. As I told you, supplemental oxygen as needed, right? If pulmonary hemodynamics are to be measured, you may get an ABG done in more unstable patients. But yes, most of the time, it's the sedation which suffices. And general anesthesia, I already told you that what are the indications of giving general anesthesia for cardiac catheterization. For pacemakers and ICD implantations, you may be called at times, right? So you should, what is so different and special about it is that if your patient is hemodynamically unstable, don't hesitate putting radial artery catheters beforehand, specifically if your echocardiography shows that ejection fraction is less than 20-25%. Usually you have been called for monitoring and giving sedation analgesia, but yes, brief GA during device testing may also be required. A word about cardioversion to conclude. Transthoracic DC cardioversion often used for atrial arrhythmias, right? Simple cardioversion is distressing and sedation is preferable if it is not a life-threatening situation. So anesthesiologists have been called for providing sedation in the ICU for urgent cardioversion. Again, I prefer using dexmedetomidine as a sedative in such scenarios. A small bolus induction agent because of its choice and sedate the procedure, right? But yes, your preparation should be adequate, right? That is important. Not going into the detail of electrophysiological studies. Now coming on to the touching about endoscopy, right? At times you may be required for giving sedation for endoscopies, right? That is there. So you should be having a facility for supplemental oxygen. You should be having a facility for bite block. For supraglottic devices, these days, LMA gastro is there, through which you can give anesthesia as well for endoscopy, and as well as you can maintain the patencies, and your endoscopist can put a scope through it. Again, the favorite cocktail is you can use a bit of midazolam, fentanyl, and dexmedetomidine combos for that, if at all is required. Right, IVF-OT I'm not touching because earlier it was considered as a remote location, but now it is like in any other operation theaters, right, where the general surgeries or the anesthesia is being given. Just to tell you that if you are anesthetizing your patient for in vitro fertilization procedures, specifically your ovum retrievals should avoid inhalational agents, including nitrous oxide, because they have teratogenic effects. So this is what I wanted to say about it, right, in this particular thing. Last few words about complications in NORA. Most commonly, you encounter respiratory complications, right? But believe me, if you have done a good planning, right, if you have a well-checked equipment, if you have plan A, plan B in place, the chances of complications in NORA goes down to drastically low levels, right? That is important. Respiratory depression can be seen during NORA. Importantly, if you're over enthusiastic about using higher dosage of sedatives, if you're not patient enough, right, then these chances are highest. So you should be very, very patient. The anesthesiologist should be very patient. That should give much time, should not succumb to the pressures. I repeat once again, right? If your patient is having unexplained bradycardias while NORA, the first thing should come to your mind is the cause is most probably respiratory, then the cardiac, right? If you think likewise, you're likely to save your patients. It is said that about 10% of anesthesiologists have no backup plan for unanticipated difficult intubations. It is crucial to be familiar with the difficult airway algorithms. Call for help as early as possible. As I told you, you should have system in your place, in your institution, that if your phones are not working, how you can ask for help at distant places, right? That is particularly there. The most common event in NORA claims was inadequate oxygenation and ventilation, which is preventable with vigilant monitoring using pulse oximeter and capnograph. Both are important. You should not compromise on monitoring standards. If you do that, right, the chances are much lesser. Another important complication which can occur is hypothermia. I re-emphasize, it's a cold environment, so proper warming of patient is important, specifically if it's having a high risk of aspiration or post-operative nausea and vomiting. So they need to be fasted accordingly. Same fasting guidelines needs to be followed as you do in all the cases. Specifically, be more vigilant if you're using oral contrasts, then risk of aspiration is higher. Your patient may be having hypovolemia and hypoglycemias. So prolonged fasting is not at all advisable. That is there, right? You should always follow the guidelines which are being laid by our society, say Indian Society of Anesthesiologists also had guidelines in place about fasting and hypoglycemia. You should not violate that. So what are the take-home messages of my talk? Yes, you are away from your home, so be more alert and ready with all the gadgets, right? In our home, we are the king, but at somebody else's home, we are the guests, but we have to be cerebral guests. We should not hesitate in communication. Be vigilant with sedative doses and its complications. You should be knowing in hand. I re-emphasize, don't be ever enthusiastic, over-enthusiastic in adding more and more dosages, rather than add different agents, rather than increasing the dose of a single agent. This should be my take home. As airway away from us, so always be attentive, and frequent monitoring needs to be done. Key to efficient and safe NORA practice in children relies on a very good PAC. You do PAC in investigations like you do in any other case. Thorough understanding of anatomical and physiological variations in children is very, very important. The knowledge of the unique pharmacokinetics and drugs of individual sedative agents is must. Understanding the requirement of the procedure and efficient team communication between the anesthetist and non-operating room personnel is very important. Even a radiological technician can help you in time of need. You should not underestimate him. He has seen anesthesia being given to MRI patients, maybe more than you, right? You may have less experience than what he has seen. So if he is telling you something, you may respect his commands cerebrally. Keep your calm, very, very important. Improvise yourself and be the conqueror. Thank you very much. I bring greetings and wishes from Maulana Azad Medical College, New Delhi. Right, my two younger friends who has helped me out in getting the material for this talk, Dr. Deepak and Dr. Vijit Kumar. These are my email IDs and phone numbers. If anybody has a query after the talk, even they can contact me. Right. Thank you very much. Thank you, Team ISA.
Thank you so much, Dr. Amit sir. That was a very nicely described anesthesia at remote locations. I'm sure all the postgraduates, if they have any questions, I mean, in fact, you have already also dealt with all the questions that would be asked in the exams and that are normally asked in the exams right at the beginning of your talk. So, sir, these ISA online PG classes are held every Monday from 5 p.m. and these are also live streamed on YouTube, and these are also recorded. So anybody who misses out on these lectures, they can very well again recapitulate and revise everything on the YouTube channel and on the ISA website.
Amazing.
So, yes, sir. This is a very nice initiative by the visionary leadership that we have at ISA right now. So this is the 26th in that series, sir, today.
Wow.
And yeah. And if you're ready, sir, we can just take a few questions that have cropped up in the chat box.
Yes, please.
So, Dr. Srinath Atriya wants to know about a 3-year-old child. I guess it's a child 3-year-old with history of conversions for MRI. What are the drugs available? What are the options for doing this MRI for this child?
Right. It's a very good question, Dr. Nishant, and we all have been seeing such patients in our routine practices also. Right. I would like to combine this question with one of the question from Dr. Muthu Kumar also. Can we use ketamine for a seizure disorder patient in MRI? I'll give both the answers in one go, right? If you allow, right? That is there. So one thing is very, very clear from my talk, that if a child is coming for an MRI who is having a history of seizure disorder, general anesthesia is the answer. You should not at first place go for any kind of mild to moderate sedation, right? That is first message which I want to give. Now, the secondly, if you're planning for general anesthesia, right, that is there, what all agents, that is the most of the time we are very confused about, what all agents we should be using in a patient with seizure disorders, right? Now, number one, thiopentone, right? You can be using thiopentone, the intravenous thiopentone can be used, right? That is there. And yes, ketamine in patients of seizure disorders is not anymore a contraindication, right? There is enough literature available with high volume literature in good standard texts also, that if you're using a controlled dose of ketamine, even in seizure disorders, it has been seen that it is not associated with raised ICP. That was our concern since years, that ketamine increases raised ICP. So we should be avoiding in a patient who is having a seizure disorders, right? So voluminous literature now says that ketamine has been raising ICP only in cases of traumatic brain injuries. Right, the thing which has come since age old was that the studies have been done on patients of TBIs, right, where the ketamine has been studied and found to raise ICP. But if patients of seizure disorders, non-traumatic ones, right, safe dosages, it is a very wonderful and a safe drug, right? Those who are postgraduates can Google role of ketamine in raised ICPs. My own review article is published in Korean Journal of Anesthesia, right, where I've discussed voluminous literature in that review article that it is one of the safest agents, and the notion should be out. Non-traumatic patients, seizure disorders, you can be using ketamine. If you're still apprehensive, use thiopentone, right? You should be using benzodiazepine like midazolam in a patient with known seizure disorders. We all know that the combination of midazolam and thiopentone is one choice, or a combination of midazolam and ketamine is another choice in seizure disorders. But yes, always secure the airway first in a controlled settings, right? That is there. Get an MRI done. And again, extubate your patient in a controlled settings, because at the time of extubation or reversal, again, likelihood chances that your seizure patients can throw a seizure. So you should be very well versed with it.
Yes, sir. In fact, ketamine has been used as a drug for refractory epilepsy. Also,
very true. Very true.
So that aspect of ketamine is also there, sir. Continuing with this, Dr. Veena Asthana wants to know about your experience with rectal thiopentone. I think you mentioned a little bit of it during your talk itself.
Rectal thiopentone we have been using. We all have been using, earlier, but since almost 5-6 years, I have not even single time given a rectal thiopentone. Most of the time, I have been using rectal thiopentone for radiotherapy procedures. Yes, I discussed the dose that infant feeding tube was inserted per rectum and 5 to 6 mg per kg. But the main problem was the absorption was unpredictable. Right, that is what was there. The chances of infection on that particular asepsis maintenance was a problem. It was messy or filthy. And when we have better agents available with us and better routes available with us, so with my little experience, I can very well say that it has now replaced, the newer agents that have replaced rectal thiopentone, like dexmedetomidine and a cocktail of midazolam and ketamine. Right, that is there. Another question I can see, Dr. Nishant by Dr. Veena, about melatonin. Right, which I can see Dr. Veena again answered it, but I don't hesitate saying it that I don't have any experience, of use of melatonin. If you or Naveen sir or any of the seniors can have used melatonin for these procedures, we're most welcome to share.
So regarding melatonin, sir, I don't have much personal experience, but there is literature in which they mentioned that oral melatonin given approximately 60 to 90 minutes before surgery provides anxiolysis as compared to midazolam at the dose of 0.2 milligram per kg. But the sedation is not as good as midazolam. The advantage with the melatonin is that it does not affect orientation, so that the cognitive aspects such as memory retrieval, etc., are better preserved with melatonin. But personally, sir, I don't have much experience with oral melatonin.
Certainly.
Yes. So we can. So what we'll do is that by the end of this talk, what I'll do is I'll unmute everybody, and they can just share their experience. If anybody has any experience with the rectal thiopentone or tablet melatonin, they can just share their experience.
They may be able to justify even more. Yeah, concentration which we were using was 5% thiopentone when we were using rectal thiopentone, 5%.
Yes, sir. So there's a question by Muthukumar Rajgopalan. How to manage if there is no MRI compatible boils and monitor? So do you advocate going ahead with the MRI, and how do you manage if there is no compatible boils or monitors in an MRI suite?
Long back when Dr. Nishant, we also didn't have it. So the kind of a makeshift arrangements which you could move was that the monitoring with long leads, we have been keeping it outside the MRI suits. The non-compatible monitors we have been using earlier, and then we have been using cylinders. At least you should be having an MRI compatible cylinder if you don't have an anesthesia. That is the minimal requirement, I must say. If you don't have a facility for a compatible oxygenation, my advice is don't go for it. That is there. At least a MRI compatible oxygen cylinder should be there in an MRI suite, and should be having a long, and as I've shown it in the diagram also, in the one of the pictures also, that your circuit should be long enough, that is there. Your monitoring you can be doing monitoring from outside the MRI suite as well, that is particularly there.
Yes, sir, absolutely. I mean, many times we see that the anesthesiologists are compromising. I think that is one area where if you can get an MRI, which is such a costly thing, they should have good compatible machines also.
Very true.
So, Dr. Muthukumar Rajgopalan also wants to know about intranasal drugs for procedural sedation.
Yes, I've touched upon one thing, that is intranasal ketamine also. I've shared my experience also, and what literature also says is the same. And this thing, that intranasal ketamine is very, very a wonderful agent, which is now available in the market also. Other than that, intranasal midazolams have also been, people have been using it, with good results. My experience with intranasal ketamine is not, intranasal midaz is not much. We have been using oral medas, but yes, intranasal ketamine, is going to be a game changer, and most of the time for the procedures, it is pretty safer. The dose is almost the same, which we have already discussed, as the oral dose is there, and it's very, patient friendly also to use it. Right, and this is there. At times, the oral ketamine style doesn't like, but intranasal ketamines, they're very, very happy. So it's the future of procedural sedation.
Okay, so you use intranasal ketamine, sir?
Yeah, intranasal ketamines with a very good results.
That is good.
Not only for procedural sedation, Dr. Nishant, I've been using it even for reducing the separation anxiety in the kiddos before general anesthesia.
Triclofos. What is the dose of triclofos for pediatric sedation?
Yeah, chloral hydrate, I've already mentioned in one of my slides also, that is there, and we have been using somewhere around 30 to 50 mg per kg, around 40 to 50 mg per kg of that thing. Less than, I've told specifically, if the child is less than 4 to 5 months of age, that maximum dose is 30 mg per kg. And if it is more than 4 to 5 months of age or smaller kiddos, you can go up till 50 mg per kg. That is pretty safer. But yes, time is important, that it has to be given almost an hour before, So that is again important.
Yes, at triclofos 50 milligram per kg. And Dr. Veena again wants to know, this was asked by Dr. Gigi, I think. Dr. Veena Asthana wants to know about the choice for sedation for BERA, a brainstem evoked response audiometry. Do you have experience with that, sir?
I only have a theoretical experience with this, whatever the literature says about BERA, because in my facility, we are not getting those BERAs done under anesthesia, and our services are not needed, for that. But whatever literature says is, it's most welcome if somebody has an experience, you can share that. But yes, midazolam ketamine combination again works very good for BERA also. Right, it's a good combination for BERA, both combination of midazolam and this thing. At times you have to give anticholinergics like glycopyrrolate atropine, specifically in your BERA patients, right, when you're using this combination. So, but any of the seniors, if they have their first-hand experience about BERA, I would also like to hear. And this is what text, the combination is what the text mostly people have used.
Okay. Dr. Anita Kohli, she wants to know about special considerations for children with Down syndrome for MRI.
Intelligent question, again a nice question. My first take on that particular thing is that whatever the anesthetic concerns you are having for a Down syndrome, for any kind of a surgical procedure, you are having it the same standards, the same concerns. The airway should be managed beforehand. Right, that is important, right, because these patients are considered difficult airways. That is particularly there. At times, these patients have myopathies also. So use of muscle relaxants, very judicious use in that. Extubation to be done in controlled settings. So whatever for any kind of surgical procedure you are having a concern, you should be doing the same thing even for a short procedure, CT scan in a patient with Down syndrome.
Yes, sir, and that is why the initial slides that you presented, that is very useful for the postgraduates, the three-step approach, the environment, patient, and the procedure. If we are keeping that in focus, questions like this and this sidetracking, they can very easily be answered and very well answered by the postgraduates.
Very true.
So,
thank you.
Dr. Shrilaja Kambathula, facilitator, she wants to know about neonates and infants What drugs cannot be used? Dexmedetomidine infusion needs MRI compatible syringe pump, or can it be given by a burette set?
Again, an intelligent question, Dr. Nishant, that the first part says neonates and infants, what drug cannot be used, right? That is there. My take on neonates is always that feed, wrap, and scan technique, which I already mentioned. Most of these patients even don't need any kind of a sedation, right? Just feed them well, cover them well, and short procedures can be done without even giving any sedation to them. But yes, if you have to use the sedation on these kiddos, right, better to avoid opioids. Opioid-free sedation is the technique for a smaller children. Dexmedetomidine is again one of the favorites, but yes, neonates, infants, I would like to avoid giving propofol to them. Number one, I would also like to avoid giving opioids to them, right? Even the benzodiazepines, they're very, very sensitive with them. So my drug of choice for them, if you ask me, is again ketamine and dexmedetomidine. These are the choices. If at all your kiddo needs sedation, I re-emphasize, right? Most of them don't need it. Dexmedetomidine preferably to be given in infusion pumps only. But yes, if you don't have an compatible infusion pumps, right, that is there. I again say a bigger infusion lines can be used, and you can keep your pumps outside the MRI suite. That can also be used. But yes, if you don't have at times, but you should be very, very having a controlled on a burette. Burette is not an advisable something specifically because you are not, immediately next to your kiddo. Your neonate infant is almost gone into your this thing MRI machine, and your burette set might also be very, very, closer to that, and access to your burette set may not be, very, so not a very good idea. Rather use a big extension line. If you don't have a compatible pump, that should be my take on that.
Okay, and regarding rectal thiopentone, sir, what is the
I think we had discussed much at length rectal thiopentone. Nishant, I've been telling
this concentration of thiopentone, is it what percentage?
So I think that 5% was used at the technique rectal thiopentone, right? That is there.
Okay. Dr.
We can unmute all now.
Right, sir.
And with an option to unmute, everybody can unmute themselves and interact directly with Dr. Amit. And yes, he has very rightly said that as far as MRI compatible machine and equipments are available, whether they are anesthesia machine or the monitors or the infusion pumps. Now, wherever it is being installed, they keep a provision for central oxygen duct into that particular suite, along with MRI compatible machine and the monitors and the infusion pumps. Yeah, everybody, we all have gone through the same phase where when MRI was initially installed 20 years ago, and we were doing the procedures with long extension tubings and long pulse oximetry and monitors were outside and the probes were inside. But we all have developed and progressed over that thing. And when we are going to install such costly machines, the cost of anesthesia machine equipments is very, very meager. So nobody is taking chances nowadays. So we should be all well equipped. As he has very rightly said that we are working at a remote location where we are working in an unfamiliar environment. We are almost going there once or twice a week at the most. And in institutes, we are doing rotatory postings also. So we're working in unfamiliar environment with backup is less and your colleagues are also less. And most of the time you are at different buildings. Now we are all spread up in different blocks. So better to be safe and to err on a safer side. Still, there are any more questions and somebody wants to interact with Dr. Amit, you are all unmuted and you can we can take some comments or remarks from all of you, whether it is postgraduates or seniors, they're most welcome. What our teachers have taught is that don't be unsafe at remote locations. Don't be unsafe. So play safe, and it is always better to err on a safer side.
If Dr. Shailaja is around, she can just share her experience with melatonin. that is used by their pediatricians.
Hello.
Yes, madam. Dr. Jyotsna, please.
I'm Dr. Jyotsna from Sangli, Maharashtra. I came across one MRI patient who was pregnant and convulsing. I was a little skeptical to give anesthesia to that patient. Because, should I take special consent that baby will have some problem or whatever?
For MRI?
Yes. She was sent for MRI. Why she was convulsing like that? Pregnant patient.
Ma'am, what was the hurry in getting an MRI done before the seizures get settled down, and then we can get the procedures done?
Yeah, I sent that patient back. I said, told that physician that you control that seizures and then send.
Yeah, certainly, yes. That should be the approach. As Naveen sir has also said, the safety is the utmost importance,
Yeah. And if it is compelled that during convulsions you are supposed to you are supposed to do MRI, then is special consent needed for not for that patients that we take, but for baby.
As far as
life of baby.
As far as literature says that MRI does not have any proven adverse effects on mother and baby. And there are many case reports and cases.
It's anesthesia.
And anesthesia related concerns are the same, ma'am, like for any surgery, if you are anesthetizing and giving general anesthesia to this lady also. So it will be mentioning all the concerns and take the consent appropriately as for anesthesia concerns.
If it is in the first trimester, then definitely rest will be different.
Certainly.
And second and third trimester rest will be different. So, but yes, you have to. It is always better to document the risk involved in a patient who is pregnant with convulsing.
Yes.
But
yes.
As far as procedure is concerned, MRI, otherwise specific consent for MRI is not required.
Okay. No, for MRI we don't take. Okay.
Yes.
Any other questions or comments? They're most welcome. I think Amit needs a good cup of coffee, and he has been.
Thank you so much, sir.
And you have covered different aspects of and non-operating room anesthesia or anesthesia at remote locations, which is a very common topic for a theory exam. And I am very sure that the residents must have been benefited from your teachings as well as your own experiences. Thank you for sparing your valuable time and to be here with us for the ISA online PG classes. I'm very sure you will like to join us soon for some class few months now in the year 2022. And next week we shall be having a class on total intravenous anesthesia, a bit extension of this thing also, and where we shall be talking about different aspects of total intravenous anesthesia. And we're just going for a slight change in the presentations. There will be three small talks by three speakers, Dr. Tushar Choksi, Dr. Nishant Kumar, and Dr. Shiv Kumar. So they will be sharing their experiences. So it will be on total intravenous anesthesia. See you all next Monday, 5 p.m. Once again, thank you, Amit and Nishant. Thank you very much.
Thank you, sir.
Hello. Sir, 1 second, sir. Dr. Shailja here.
Yeah. You were talking about melatonin, madam.
Yeah, good evening. You were asking about the melatonin, sir. Our pediatricians use about 1 mg for infants and 2.5 to 3 mg around for older children, sir. And not for all the kids, but where anesthesia concerns are more, they try to manage with that. But the success rate, when it doesn't go well, then only they come and ask us for help. So most times they are able to manage is what they say, but I don't have first-hand info on that.
Dr. GNS has also raised hand. Please unmute yourself.
Sir, only one question to Amit sir. Sir, in the initial part of the presentation, sir has told about a conjoined twin that neonate he's given a full brim.
I was expecting that. Yeah, go ahead, ma'am.
He has given us sedation. Can you please explain on that in brief, just for 1 minute, sir, please?
Sorry, I didn't get your question. I was expecting a discussion on that, but I didn't get your question. Your voice cracked in between.
Conjoined when newborn, you have told that one was kept causally by feeding it full to the brim of the stomach, and another you have given sedation for that newborn to be sedated. How is it possible? Can you please?
Yeah, we might have got such cases done, I'm sure, and that's particularly there because our main concerns is because they have the common circulation at times. So whatever drugs we give, there are chances that the drugs can go into both the fetuses. So we really had a good thought on it that how to minimize those drug dosages. At the same time, both the kids become immobile as well. So then we totally asked the history from the parents, which out of the two is more quiet, in a general day-to-day this thing, which becomes more sleepy kind of a thing. So and the one which was little lull, and then this thing we fed him out so that he doesn't require any kind of drugs being infused to him. And the other kiddo, as I already told, that I have given oral midazolam and ketamine to that particular thing, right? And the procedure can be done both, and even I didn't need dexmedetomidine in that particular this thing because child was too small. So both became immobile. I can cut short on sedative doses, and it can be done. So at times, if your kiddos, both of them you can feed and you can get it done in first place. If it fails, because these are not emergency procedures, you can easily get your child in a second sitting and get your planning done. So specifically, this is the newborn, neonates I'm talking about. And that FET technique really works. So I gave them oral midazolam and ketamine, a bit the second one, and the entire procedure can be done very safe, had been done very safely.
Okay, sir. So the one which is active, you have made them to feed it to full. Am I right, sir?
Yeah, and the feed, जो भी normal वो लेता है ना, feed लेता है, breast feed, whatever taking. We don't know what is till brim, stomach till brim. We can't know that. Yes, but yes, whatever routine feed the child takes, we have just given it to them. We have just told them to wait for an hour or 2 hours or so. And after that, the second child, we have just given those oral drugs. And after 30 minutes or so, we have taken the kiddos, both the kiddos, and it was done very nicely.
Thank you so much, sir.
Thank you, madam.
So thank you, Dr. Amit, and see you all next Monday.
Thank you so much, sir. I really a minute that as an ISEN, really I want to congratulate and thank the entire team that it is very, very good initiative for all our postgraduates. My own place, the people wait for this Monday talks, so that is there today. They were saying that it is from our institute somebody is taking, otherwise they have been listening it to other well-read teachers. That very, very wonderful initiative, and thank you so much for inviting me on this platform and interacting with the young minds, right? I hope I was useful to them. So thank you, Team ISA. Thank you, Naveen sir, and thank you, Dr. Nishant.
Thank you very much.